Hi, I'm Dr. James Rynerson, and you're watching this video because someone has told you in the past that you have blepharitis or dry eye disease. And that's what we're going to talk about today, is this disease known as blepharitis, sometimes known as dry eye disease. You're here because you've probably seen a lot of doctors already, and you have symptoms of scratchiness, grittiness, dry eye, foreign body sensation. Maybe you're red, maybe you're burning, and maybe you've seen multiple doctors. Maybe this is your first visit to see about dry eye disease. But if you're one of those unfortunate ones who have seen numerous doctors and you keep hearing the same thing over and over, to scrub your eyelids, to use artificial tears, maybe you've been put on some expensive prescription eye drops, and nothing seems to work, that's pretty much how it's been going with dry eye now for decades. Now, whose fault is that? Well, I can tell you right now, it's not your doctor's fault, really. Here's the problem with blepharitis and dry eye as a disease. We have never understood it. And even today, in our residency programs and our training programs, dry eye and blepharitis is taught as the following: that it's complex, that it's confusing, that it's overlapping presentations of different diseases, that it's chronic. There's nothing you can do about it. It's just going to get worse. This is what your doctors that you've seen before have been taught. They don't know the new understanding of dry eye disease that's now been out for just a few years. And it's this new understanding that's making all the difference in the world. So don't blame your prior docs. They were just treating you the way they were taught in the residency programs. It takes a while for a new theory and new understanding to really take hold. Now, you're going to learn about dry eye disease from watching this video. And when I get through, you're going to understand dry eye disease better than 99% of all the eye doctors in the world. At least right now, until everyone gets on board. But you'll understand it. If you're going to get your eye disease treated, it's important you understand your disease. So let's get started with that understanding right here and right now. The number one word that you need to learn if you're going to understand your disease process is biofilm. Biofilm is the key, and it's what was missing forever in the understanding of dry eye disease. Now, what is biofilm? Well, biofilm, it's a polysaccharide substance. It's made by bacteria. It's their fortress. So think of a medieval fortress on a hill that nothing can penetrate. You see, bacteria have been around for hundreds of millions of years, longer than we've even existed as a species. And bacteria want to survive, just like all life forms want to survive. And they learned very early on that if they wanted to survive that harsh world out there, where everything is eat or be eaten, that they needed to build something that protected them, something that was impenetrable. And that's what biofilms are. They're absolutely impenetrable. So antibiotic drops can't penetrate biofilms. A surgical scrub before a cataract or a glaucoma or any other surgery, it cannot penetrate biofilms. Our own white cells cannot penetrate these biofilms, and bacteria build it that way on purpose, impenetrable. They want nothing coming in. It's a place just for them, and they survive in there. Because as I said before, something will eat that bacteria and make a food source out of them if they're readily available. And within biofilms, they can't be touched. Now, they build these biofilms in nature pretty much without exception. Anywhere, there's three things. First, you need a surface, obviously, to build the biofilm on. Second, you need moisture. Third, you need nutrients. If bacteria have all three of those things, a surface and moisture and nutrients, you'll get a biofilm every time. Bacteria live all over us, and anywhere they have the moisture, nutrients, and a surface, they build biofilms. So on our dry skin on our arm, there's dry, flaky keratin. There's not really any moisture there. So bacteria don't build biofilms on our body generally. But there's one spot that you're already familiar with biofilms, and that's in your mouth. Because there's moisture, there's surfaces, and there's nutrients there. And bacteria build biofilms in our mouth, except they're not called biofilms. Every time you go to the dentist and get a dental cleaning, that dentist is removing what? Plaque. Plaque is a biofilm. And bacteria get in that plaque. It's impenetrable, nothing can get to them, and they begin causing inflammation at some point, and in the mouth we call that inflammation gingivitis. Now, what happened to all of our ancestors after 30 or so years of chronic inflammation in the mouth? The tooth sockets got affected, the teeth all got loose, and they all fell out, and everyone was in full sets of dentures, and they thought it was normal that you get 30, 40 years of age and everyone had full sets of dentures. All of our ancestors, all of our founding fathers, everyone essentially. A normal part of aging. Now we know better. We know the good oral hygiene, you have a pretty good chance of dying with your own teeth in your head. It's no different for, guess what? The eyelid margin. And I mean the eyelid margin, this area right here, right in behind the eyelashes, is the margin of the eyelid. It's that little teeny space, a little 2 millimeter thick space of skin. But it's a surface, there's moisture from tears, and there's nutrients in the tears, and so you get a biofilm developing along the eyelid margin right here. Now, we're colonized with bacteria very early in life, shortly after we're born. Is that a week of age? Is that a month of age? I really can't tell you, but we all know we're colonized with normal flora bacteria, primarily Staph epidermidis and Staph aureus, that I may refer to as Staph epi and Staph aureus later on in this talk. Now, these bacteria colonized the lid margin very early. Now, these guys that colonize the lid margin, they kind of celebrate when they realize where they are. They look down at the poor bacteria on the arm or the leg and they say, hey, you poor guys in there, you have no moisture, you can't build a biofilm, you're going to get sloughed off with the shedding keratin of the dry skin. But we, lucky few bacteria who live along the eyelid margin where we have moisture, we're going to build a biofilm. And this biofilm really cannot be penetrated, it can't be stopped, it really can't be dislodged. So these bacteria living here can live in a biofilm and grow their numbers. So biofilm is key. Now, the bacteria living along this eyelid margin start building that biofilm very, very early in life, while we're infants, just maybe a few weeks or a few months of age. However, the bacteria living in a biofilm here when we're babies don't really cause problems. You don't see 1 month old or 6 months old or 1 year olds running around with blepharitis and dry eye disease. They start building a biofilm here, the bacteria do. They look up at the host, they say, nothing to see here, move along. We're not bothering you, you don't bother us. We're just building a little biofilm, we'll all get along fine. And the biofilm causes no problems. So the body really doesn't even recognize that there's bacteria building a biofilm along this lid margin. Everything goes along fine. But after a number of years, let's say 7 or 8 years of age, the bacteria kind of break their end of the bargain. The bacteria building this biofilm, the biofilm gets thicker and thicker. The numbers of the bacteria start increasing. And when those numbers increase, now the bacteria know they're in a thick biofilm. Now in this thick biofilm, they're virtually indestructible. You can't get to them. So the bacteria are confident now that they can produce something called virulence factors. Now, what are virulence factors? Virulence factors are really toxins, for lack of a better word. So enzymes, alpha hemolysins, cytolytic toxins, and these toxins are designed to break down a little bit of the host tissue where the bacteria live. Just a little bit, because the bacteria are getting hungry, the numbers are going up, and by producing these toxins, they can liberate a little bit of food from the host. Well, now the host says, hey, you broke the deal. You weren't supposed to bother us. Now we see you're breaking down a little bit of our tissue here, so now we're going to come in and we're going to wipe you out, which is the normal immune response. So inflammation sets up to come in and attack the bacteria. Our immune system triggers. And inflammation is associated with dilated vessels and leaking vessels to bring in sort of the armaments of war, if you will. The immune system is going to war against this invader. And you get edema, you get swelling, you get redness, you get burning, you get everything associated with an inflammatory response. Now, typically when the body sets up an immune response to an invader, the idea is go in there, wipe it out. We'll handle a little collateral damage. We'll accept some of that as long as we wipe out the invader and save the body as a whole. But guess what happens here? The body rushes in to fight a war, vessels dilate, you get edema, you get swelling, you get inflammation. It arrives on the battlefield, but the bacteria are safe and sound within their biofilm. It can't be penetrated. The bacteria can't be reached. So it's like an army arriving to do war, and buildings are being shot up, and bombs are dropping, and all your havoc is being wreaked on the battlefield, but you can't get to the enemy. That's what's going on our eyelid margin. Our immune response is causing all kinds of damage in an attempt to attack the bacteria, but can't get to them. Now, if our immune system had its own independent brain and could think for itself, it would arrive on the battle scene, it would start fighting, and then go, wait a minute, all we're doing is damaging ourselves. We're not able to get to the bacteria. Let's call off the attack. Let's knock it off. But our immune system has no independent brain. It can't think. So what does it do? It keeps attacking. It keeps sensing these virulence factors, these toxins being produced by the bacteria, and it keeps attacking. It doesn't know that it needs to stop. And so what actually gets damaged, the bacteria in their biofilm? No, we do. Our eyelid margin and everything within the eyelid margin. Now you might think, well, why don't the bacteria start producing these toxins right from the beginning so they get food early on? Maybe they'll grow faster. Bacteria are much more clever than we give them credit for, because if bacteria started producing these toxins, these things that cause inflammation early on, while they're still in a little thin biofilm, maybe the biofilm is only 1 or 2 years old. So the body would come in and wipe them out because they're in this nice little thin biofilm. They're not well protected. So they're smart, they're clever, much more clever than we give them credit for. They're quiet. They build a benign biofilm that don't cause problems because they don't want to be attacked yet. But once they're in a thick enough biofilm and they can sense their numbers, something happens that was discovered down at Harvard in 1968, quorum sensing gene activation. And what that means is that bacteria can sense when they're in a quorum, when their numbers are a certain level or a certain density. And they know when they hit that level, they must be in a thick biofilm. Then the genes activate, quorum sensing gene activation. Then the genes activate and start producing the toxins. That's why in a 1-week-old or a year-old, there's no toxins. But in a 7 or 8-year-old, you start getting some of those things, those toxins that trigger the immune response. And from that point on in our lives, the immune system never turns off. Now, it's not rip-roaring inflammation. It starts off very low grade, very subtle. Don't really even know it's there. And there's a lot of damage that's done from that inflammation without us even recognizing that we have symptoms. But there's damage ongoing from that point forward. And that's what leads to the disease that we're seeing now with dry eye and blepharitis. Now, the bacteria live here originally. They build a biofilm here originally. That biofilm spreads along the eyelid margin, and pretty quickly, within 6 or 7 years, that biofilm can go right down along the eyelash here and into the lash follicle. The lash follicle is a little pocket that holds the lash bulb. It can accumulate down in this lash follicle. It can get the thickness of the biofilm up to where quorum sensing is triggered, and you start getting toxins produced within the lash follicle. So once the virulence factors are being produced within this lash follicle, what happens? The immune system gets triggered. You get low-grade chronic inflammation. Now it's in a teeny little spot, the lash follicle, so there's really not much in the way of symptoms associated with that, other than maybe 10-year-old Johnny sitting over there rubbing his eye, and what's Mama always say, don't rub your eyes, it's bad for your eyes. So he might start rubbing because his virulence factors just turned on and just triggered, and he's getting a little irritation. But beyond a little eye rubbing now and then, doesn't really cause much in the way of immediate damage or really serious symptoms. Certainly we don't take little Johnny to the eye doctor because he's rubbing his eyes, right? We consider, oh, it's normal, we all rub our eyes from time to time. Well, that's probably because his bacteria within his lash follicle just underwent quorum sensing gene activation because of the density levels and started producing some toxins. And you'll see that in the form of edema and swelling around the base of the lash. So folliculitis is the first stage of this disease known as blepharitis. Blepharitis really means lid inflammation. Bleph is lids, itis is inflammation. And you'll see later on that dry eye is just a late manifestation of that same disease. You see, this disease, remember when I said it was chronic and complex and poorly understood. We used to think it was overlapping presentations of different diseases, that dry eye and blepharitis were separate diseases, but they're not. It's all the same disease caused by one thing and one thing only, biofilm. Now let's first of all look at a normal eyelid. See this eyelid right here? It's a very boring eyelid. There's no pockets of edema, there's no swelling, there's no inflammation, there's no nothing. Just nice flat skin along each eyelash. But you go over here to this eyelid and you get what I call the humpy bumpies. You get swelling around the base of each eyelash. That's folliculitis, inflammation of the lash follicle. In darker skinned patients, you'll get little white dots that will stand out. You can actually see the little white dots. Whereas in Caucasian patients, you can't see that, but you'll certainly see the edema, the pockets of swelling along the base of each lash. Folliculitis, that's stage 1. Relatively asymptomatic, doesn't cause damage until much later in life. Now, what's the second stage? Well, the second stage involves the meibomian gland. Now, let me show you on the eyelid model what the meibomian gland is. That's this large gland right here. So again, here's the eyelid looking at someone, the eyeball's back here behind, here's the lashes in front. We look at the side view, and we have a meibomian gland right here within the structure of the eyelid, and they are all along the entire length of the eyelid margin, this gland right here. It's the most important tear gland we have. It produces the oil, which is the outermost layer of our tear film. Our tear film consists of the outer layer being oil or meibum. The middle layer is aqueous, or the watery portion of the tear, and then the layer of the tear that's against the eye is a mucus layer. The job of the oil is to spread the tear film out uniformly across the cornea, number 1, and number 2, to prevent evaporation of the next layer in the watery layer, prevents it from evaporating. The oil acts as a protective layer for the rest of the tear. Very, very important. This is the next structure to be involved. Now, it's a much larger structure, as you can see, than the lash follicle. There's a little narrow ductule coming up here to the lid margin itself where the oils are supposed to dump out. It's very narrow. So along here, alongside the eyelash, where the bacteria can easily access the lash follicle, it's much more difficult to access this gland. And the gland's much bigger, so it takes longer to have an effect on it. But let's say after 30 or 40 years, that's how long it actually takes, this biofilm finally manages to gain access against this outflow of oil, and in spite of a narrow ductule, it finally gets access to this meibomian gland, and it colonizes the gland here. Now, the biofilm's a polysaccharide, as I said earlier. The polysaccharide mixes with the meibum, mixes with the oil, and you get a sludge. So the first thing that happens is this sludge tends to occlude this narrow neck of the gland here, and you start getting less oil output. Eventually, it blocks it completely, and you get very little, if any, oil output. Now that sludge keeps trying to move up this ductule, trying to get out, because it's constantly being produced in here by the bacteria, and your meibomian gland's constantly trying to produce meibum, or trying to produce the oil. So that thickened mixture starts trying to work its way up. But then, here's something interesting that happens. It can't get out. It can't get out through that little ductule. It gets up here to the top, but something blocks it. What do you think that is? That's the original biofilm layer that's been there since birth, nearly. Like a layer of saran wrap is on your eyelid margin. So imagine tonight when you go brush your teeth at home, imagine taking your toothpaste tube and wrapping the end with saran wrap and giving it a squeeze. What are you going to get? A dome of toothpaste. That's what you have all along the eyelid margin. See those little white dots? Those are like little domes of toothpaste over top of every meibomian gland that's all along this eyelid margin. So it rises up, pushes up, runs into the original biofilm layer, and it's trapped. Now it gets thicker in here. It's already gotten thicker, and so now we know what's going to happen. Quorum-sensing gene activation. You're going to get toxins produced. Now the inflammatory response is being set up inside your meibomian gland. We call that meibomianitis, or inflammation of the meibomian gland, also known as MGD, meibomian gland disease. Now this is a bad state of this disease process because that inflammation will eventually kill off these meibomian glands. And then patients are really miserable and really in trouble, and it gets harder to treat at that point. Now here's what that looks like on our little chart here. Here's the eyelid margin here, and you can see this just beet red posterior portion of the eyelid margin corresponding to this portion here where all the little bumps are. You can see the little domes of toothpaste, the little white dots here. Little domes of toothpaste trying to get out of your meibomian gland. Here's one over here, not quite as red, but this is an interesting picture because it shows that these little domes are actually what's coming from the meibomian gland itself. It's nothing that came in and sat down on top of the meibomian gland. It's not keratin or anything else you might have heard. This stuff is coming out of the meibomian gland. And here's an example. So here's a gland that pushed its contents up, that sludge. I call it meibofilm. Meibofilm, or meibum mixed with biofilm. I call it meibofilm. So the meibofilm pushes up against this, and in this case, right here in this gland, it found a little defect in that top saran wrap layer of biofilm, and it squirted through. And if you look closely here, you can see a little ribbon of toothpaste. It's kind of curvy here. It looks just like a ribbon of toothpaste that's squeezed out of your toothpaste tube. That's what's coming out of your meibomian glands. That's what's stopping up your meibomian glands, and that's chock full of toxins, and it's going to cause inflammation and eventually death of the gland. So this is the stage where I would generally see patients and advise them on what's going to happen to their glands if we don't address this biofilm. So that's MGD. That's stage 2 of this disease, dry eye blepharitis. A good term for this overall disease, I think, is dry eye blepharitis syndrome. It's all one disease, but it's a syndrome in that it presents differently at different stages of life, depending on what structure it's affecting in the eyelid margin. Now let's look at stage 3. What's stage 3? Well, stage 3 involves the lacrimal glands. Now the lacrimal glands are located way up here under the superior orbital ridge. It takes a long time to get there. You've got a long distance to travel from the margin of the lid all the way up to a lacrimal gland, which live along the top of the lid and up behind the superior orbital bone. It's got to creep very slowly in an attenuated fashion, very slowly up the inside of the eyelid margin, is the theory, as how it accesses those glands. But eventually it does. Now this is in very much your elderly population, 75 to 80 years old. It's less common to see this aqueous insufficiency where the lacrimal glands are attacked. Much more common to see this because it's an earlier stage. But eventually, if this disease is not arrested, you'll have involvement of the lacrimal glands. You have very low tear lake. By now you have nearly full thickness lid inflammation. Instead of just the posterior edge, you have the whole eyelid margins now inflamed because all structures are affected by biofilm here. And if that goes on another 5-10 years, well, the tendons can be affected. The eyelid can roll out or roll in. Patients will come in like this with the worst lids you've ever seen, and they say, oh, I'm fine, I have no symptoms. I used to 10-15 years ago, doc, but I got over it. No, you didn't get over it. You just killed off your nerve endings in your eyelid from this chronic inflammation. You see, inflammation takes no prisoners. It affects everything given enough time. Now you might think, well, how come doctors haven't known about this, right? How is it we're just now learning about this? What doctor in their right mind would think that the 90-year-old that they just saw with this lids rolling out and destroyed eyelid had the same disease as that 10-year-old who came in with some early folliculitis? No one would think that's the same disease. But this disease is one of the only ones I can think of that lasts a lifetime. And it looks different at each stage of life depending on what structure is now affected by the biofilm. So you got to know biofilm to understand this disease, and you got to know a little bit of lid anatomy, not too much, but you got to know about eyelash follicles, about meibomian glands, lacrimal glands, and then end-stage disease where everything's affected. So as you've now learned, biofilm is the key to understanding this disease, and it's so simple. The funny thing is that we as eye doctors, before we knew about biofilm, we still looked at it and saw it every single day of our practices. We'd look at somebody at the slit lamp, we'd look at their eyelid margins, and we'd see debris stuck in the lashes. What did we call it? Did we call it biofilm? No, we didn't know biofilm really existed or what it was in relationship to the eyelid margin. We call it scurf. No real medical definition of scurf. Debris, crud, junk, dirt, not supposed to be there. And we would tell patients to go home and clean that scurf off their eyelashes. That must be the problem. That must be why they're having symptoms. It's a task that's virtually impossible for patients to accomplish. scurf was really biofilm, and that was the key to dry eye disease. As you can now probably guess, removal of the biofilm is the key to treating this disease. That's also simple. So the understanding is simple, the treatment is simple. Remove the biofilm. And that's done two different ways, and they're both very important. The first way is to use a Blepharitis device, which has a little sponge that attaches to it. And this little sponge sticks right down in here. And the doctor will use this little spinning sponge soaked in a lid cleansing solution and go along and debride, remove all of the biofilm along the eyelid margin. You see, once biofilm's stuck on an eyelash, it really can't do anything. The eyelash grows, it'll pull a little chunk of biofilm off, then you can see it, but at this point it's inert. It's on an inert eyelash. You can't inflame an eyelash. It's the biofilm that's here. That's the problem. And that's virtually always been invisible to us. We look right through it. It's translucent. This is where it's causing problems, not a piece stuck to an eyelash. So this is what we have to clean, the entire lid margin, especially the tops of the meibomian glands, to remove that saran wrap layer, so then we can try to get biofilm out of here, out of the meibomian gland. So the Blepharitis is first, a debridement procedure. It just feels weird. It doesn't hurt. Takes about 8 to 10 minutes max. Once that's done on both of your eyelids, then the second step is to use this iLux device. The purpose of the iLux is to remove biofilm from where? From within the meibomian gland. So Blepharitis removes it here. The iLux removes it from within the gland here. So he'll use the iLux by Alcon, slip down over the eyelid margin, and give it a little gentle squeeze. The back of this little plate here heats up, so now we're melting that meibofilm, squeezing it, and rolling it out of these glands, evacuating them essentially of the toxins, the bacteria, and their biofilm. I'll have patients say, oh, it's like you're popping a zit. Well, sort of. We're squeezing that junk out that you don't want in your meibomian glands anymore, because that's getting full of toxins. We got to get that stuff out of there. Once we get that biofilm out, now your gland has room to put meibum back in here, put tears back in here again. Now you have a better mixture of oil to biofilm. Now you're unroofed up here. Now it can start flowing out better. But it's important to understand in this disease that one treatment won't fix this. You're not going to get your teeth cleaned one time at your dentist and say, that's it, I never need to get my teeth cleaned again, right? You're not going to brush your teeth once in your life and say, that's it, I'm done. Because bacteria are still everywhere, right? There'll still be some down in here. They're here. They're never going to really go away. We're never going to have sterile eyelids. So this is something you have to keep up with. Now, once we get you to maintenance therapy, which we think is going to be in most people every 6 months, you get the debridement, you get the squeezing, the heat and the squeezing. Every 6 months. But how do we get you to an every 6 month schedule? We can't do that in the beginning. The biofilms had a 50, 60, 70 year head start, right? So one treatment's not going to do it. One treatment every 6 months is not going to do it. This treatment needs to be done more often early on in this disease, so we can get to a point that we can stretch the treatments out and get you to your maintenance schedule. What does that look like? Typically, we're going to do a treatment, let's say today, repeat that treatment in 1 month, probably repeat it again in 1 month, and repeat it again in 1 month. Now, why do we do that so often? Fighting this disease is kind of like fighting a war. General George Patton said, never take the same ground twice. And it's very important in fighting this disease. We're going to take ground against your disease and take ground against your biofilm. We don't want to give that ground up. We want to make progress and make some more progress till we finally get you something close to normal. After your first treatment, you're going to take 2 steps forward. You may take a half step back before we get your next treatment, and maybe a whole step back. Then we're going to treat you again and take 2 more steps forward and maybe a half step back, and then 2 more steps forward and maybe a half step back. And eventually, we're going to be across the room where we have normal tears, normal oil coming out of your meibomian gland. Here's what we don't want to have happen. I don't want to do a treatment today and then we wait so long before your next treatment that we're right back to the beginning of where we are today again. We lose our progress, you've wasted your investment in getting your eyelids normal, and we're starting from scratch again. If we treat and wait too long, you're right back to ground zero. So we have to treat, make some progress, and then treat again before we lose that progress, and then treat again before we lose that progress. That progress, we need to hang on to that. That's what's going to get your meibomian glands normal again. But one treatment will not do this. And one treatment may not relieve your symptoms. It may take 2 or 3 or 4 treatments before you start getting resolution of your symptoms. We got to get your meibomian glands normal. Now, one very important diagnostic tool that your eye doctor may have in his practice, especially if he has a Blepharitis, he may well have the LashCam IR, which was invented by the same person who invented the Blepharitis device. And if he has LashCam IR, you're going to see your eyelids in ways you never thought possible. The LashCam is a way that your doctor can take a picture of your eyelids at about 40 to 50 magnification in full color. He'll hold it up to your lid like this, to your eye, and with your other eye you will look at an iPad and you will be able to see up close, magnified, your eyelid. And you'll see all these findings we're talking about. You'll see your lash follicle edema around the base of your lash. You'll see the domes along your lid margin if you have those already. You can see with your own eyes your level of disease. But then very importantly, it has infrared capabilities, which is the IR portion. Infrared light can actually see through the conjunctiva of the back part of the eyelid. And it can visualize these glands and see the size and the state of those glands. Normal glands should be nice and long, and we'll show you a picture of that. Severely diseased glands may only be little nubs. It's important, no matter what state of meibomian gland health you have, that we save and protect and optimize the health of the meibomian glands you have remaining. They are vitally important to producing oil to get you to a normal tear film. So this is why we have to treat early, we have to treat often, so we can eventually get you out to an every 6-month type treatment. That is an expensive proposition. Unfortunately, having disease is expensive these days. Insurance doesn't cover this. It's all too new. Insurance doesn't cover it. It's out of pocket. Prices vary all over the country. But it's going to be your financial responsibility to get your lids normal again. And you're going to invest several $1,000s in getting your eyelids normal again. The sooner you start, the better. The sooner you start and keep up with it, the less expensive it'll be to get you normal again. Eventually, in a perfect world, everybody, when you turn 16 years old, you're going to go get your driver's permit, and guess what? You're going to go start getting your lids cleaned every 6 months. And then at that point, it'll just take this little guy, cleaning every 6 months. And perhaps we think we can avoid your meibomian glands ever getting involved and getting diseased. And now you're talking relatively an economical mode of cleaning your lids and keeping you safe. It's not going to cost you thousands of dollars your first year to try to get you normal again. The important part of this disease is prevention, if we can do that and you come in young enough. The trouble is, without symptoms, no one knows to go see their eye doctor. It's the last thing you want to do, right? Go see a doctor if you have no symptoms. But let me ask you this question. Do we wait until our teeth are falling out before we decide to get a dental cleaning? No. We know better. We've been educated. Society now knows regular dental cleanings are important to keeping your own teeth in your head. And now we know it's the same thing with the eyelid. Early, regular lid hygiene is critically important to keeping your eyelid healthy, keeping the structures healthy, and keeping you with a normal tear layer for the rest of your life. These are important things. People with dry eye can tell you, and maybe you're one of them, you're miserable with this dry eye. It's with you every second of every day. I had a patient who loved to fly, loved to ski out west. 77 years old, retired doctor. He couldn't do any of those things anymore. His eyes were constantly giving him trouble, causing pain. After his first treatment, and I'm not making any promises with your disease, but after his first treatment, he said it was the first time he'd woken up in 20 years without pain in his eyes. Now, we're talking significant discomfort. This affects quality of life. You ever been to a nursing home and see all the patients sitting around? How many of them are all red eyes, weepy eyes, pussy eyes, goopy eyes? These are miserable patients. It affects their quality of life. It affects their dignity because they know it looks terrible. It cannot be allowed to happen anymore. We have a solution for this disease. And the solution is simply a BlephX followed by an iLux, done on a regular basis. Get in front of the power curve on this disease, and then keep the disease at bay with regular treatments, just like we do regular dental cleanings. Now that you understand biofilm and now that you understand your disease, I hope you seek out an eye doctor to have these procedures done to start yourself on the road to healthy eyelids. Healthy eyelids, enjoy your life, make good tears again, and I think you will thank yourself many times over later in life when your eyelids are finally normal again and you have normal tears. So thanks for your time and attention, and I appreciate you watching.